Good evening, everyone, and namaste, sasrikal, vanakkam, namaskaram. Welcome to yet another webinar to be hosted by infection control nurses who are students of Signia Healthcare. And I'm Tankam Gumes, founder CEO of Signia Healthcare. I'm extremely delighted to be presenting these young leaders of infection prevention and control. And we have already done with, two of the webinars. I just would talk about them in a second. Just give me a minute. So, we are celebrating Infection Prevention Week. It happens in October. So that's how we came across, and we thought, we should be celebrating in a very unique manner. And we are doing this in association with Nurse India. This is a um, exclusively for nurses technology platform. You can visit www.nurseindia.org. There is one platform where you may be able to find information, you may be able to find your job inside India or outside India. So feel free to register and upload your resume also. So this is we have planned for 7 webinars, and I'm extremely proud of all of them who volunteered to hold these, host these webinars and discuss on topics which are unique, and also they are the latest evidence-based practices. So we finished with non-ventilator hospital-acquired pneumonia on 11th October by Halle. It was followed by all about extravasation Rakshita, that was on 14th. Yes, it seemed to be a very popular topic because we had more than 50, 60 people in the session with a lot of questions being asked. That was very, very interesting. Dialogues and comments and interactions will make these webinars really, really more useful for everybody else. And today we have Rajeswari, our infection control nursing officer from Apollo Proton Cancer Center, Chennai. She's going to talk about strategies to prevent infections in acute care settings. Well, we have multiple, things that needs to be taken care during the infection prevention practices, but then there has to be an approach, there has to be a strategy on how to implement multiple things same time, leading to preventing patients from getting any hospital acquired infection. So coming forward in the future, 21st, we have strategies to prevent SSI to be done with Ashwati, followed by Amandeep talking on cleaning, disinfection, environmental hygiene. Then Blessy talking about prevention of CLAPSy. And the last of the series is prevention of VAP by Feba Sibi. And so a very, very warm welcome to all of you. And we finish these two. Now we have today Rajeswari doing the session on strategies to prevent infections in acute care settings. And we look forward to having all of you in the remaining of the webinars. And now it gives me immense pleasure to invite Rajeswari on the screen. Hi, Rajeswari, please come on the screen. Rajeswari, please come on the screen, please. Rajeshwari, can you please come on the screen? Please put your video. You can share your presentation later. Put your video on, please, Rajeshwari.
Yes, ma'am. Yes, ma'am.
Can you stop sharing? Start your
Sorry,
video.
ma'am. Namaste. Good evening.
Good
Namaste,
evening.
ma'am. Namaste, all. Namaste.
So I would like you to say a little bit about yourself and how long you had been an ICN, where did you work, what's your experience, and then you can start sharing start your session. All the very
Sure.
best. And I stay off audio, off video. And the audience, if you have questions, comments, please start using the chat box and we will address them at the end of the session. Over to you.
Yes. Namaste, namaste, all. Namaste, ma'am. My name is Rajeshwari. I'm an infection control nursing officer from Apollo Proton Cancer Center. I have been working as an infection control nurse for 8 years. I am excited to share my insight on strategy to prevent the infections in acute care setting. I believe this is a critical topic, especially in our field when patient safety is top priority. Shall I share my video, PPT? Ma?
Yes, yes, sure. Go ahead.
Before I begin, I would like to express my sincere thanks to Thangamma, one of the most well-known and respected figures in nursing, not only nursing, healthcare fraternity. Her leadership and dedication have been a tremendous source of inspiration of many of us, including myself. First, we need to know the strategy. Strategy is essentially a plan of action to achieve the achieve the long-term goal. That's all. Strategy, it's like a long plan action to achieve the long-term goal. That's all. In acute care setting, it's always focused on the evidence-based practice tailored to meet the specific needs of our environment, aim to improve the patient safety as well as the quality of care. For this acute care setting, mostly it's depend upon the infection prevention strategies, including implementation of the hand hygiene protocol or personal protective equipments protocols, how to wear the donning and doffing, and maintaining the environmental cleanliness. These approaches are part of the large strategy to create a safer healthcare environment for the patient as well as for the staff members. Acute care settings. Actually, acute care setting, it means the healthcare settings that where the patient receive the immediate and short-term treatment for severe injuries, illness, or medical condition. These settings are designed to provide the rapid medical care to the patient who are critical conditions are experiencing the sudden health changes. Infection control in such settings especially crucial because patients are often more vulnerable due to their weakened immune system or maybe the invasive procedure. Therefore, care of acute care settings like infection control practice in acute care setting is the top priority. Then acute care setting, beyond some acute care settings like emergency care, urgent care, short-term stabilization, pre-hospital care, critical care, trauma care, acute care surgeries. These all including our acute care settings. Now, it always starting from the explain the common intervention or implementation, relevant implementation to the common issues. What are the problem we are facing? The intervention has to be relevant to the topic. It's always starting with the team member, the broad behavioral and social adaptive concept. To understand the different concept, if I'm introducing the new concept to the new practice to the particular new intervention to the particular issue, just example, surgical site infection or surgical antibiotic prophylaxis deviation. If they are deviating from the 30 minutes of antibiotic from the incision time 30 minutes as well as to the 60 minutes, if the doctors, if the surgeon, if the anesthetic, if the team members are not following, what the first thing I have to do it. If I'm creating the policy, what the existing policy we have, whether any difference between the existing policy or our new policy, new implementation, that the team member has to understand. Then we all have to know about knowing and doing the gap. Any implementation, it starts from first step. It has to be identifying the effective intervention. The intervention has to be little effective, not only creating the policy. After creating policy, it's lying down in the cupboard or maybe in the manual book. But the implementation policy has to be reach out to the team member. They cannot go there to your cupboard or your place. They cannot take and read it. If you want to implement, it has to be easy to read. Wherever they are taking coffee or maybe changing room, wherever they are easy to approach, we have to put it in the notice board. When anytime if they are seeing that that intervention has to reach their eyes, so then after seeing so many times, maybe it will go to their mind easily. And education and training. Education and training it is not an easy job. Whenever educating the people or training the people, not only giving the theoretical, we have to be always give the evidence-based practice that will change the behavior of the team members. When after giving implementation and education, it has to be evaluation mode. Evaluation mode always it leads to the success of our intervention. Then improvement, whenever if I'm approaching to the doctors, if my the senior consultant, if they are not following the surgical antibiotic prophylaxis, because I am practicing, they will say I am practicing from how many years, 40 years, your age is not at all my practice, why are you coming and saying this is infection control practice? If I am going and telling this is the way, their attitude, if I am going with the guidance, if I am going with the guidebook, the evidence based practice, always it's matter. Then identifying and applications of the strategies towards the improvement. Whenever if I'm giving implementation, intervention, planning, whatever it may be, my aim has to be improvement. The process always to ensure the process towards the improvement. Strategies for implement. The strategies we have three types. When any issues, if like a surgical antibiotic prophylaxis or surgical antibiotic prophylaxis leads to surgical site infection, it's always starting with the planning. The planning has, whenever there is issue, we have to have some project. So I have to tell, I am going to have a surgical site infection prevention project or surgical antibiotic prophylaxis complaints has to be improved. I'm going to plan project. Then after project implementation, I have to procedural implementation. That means I have to call my team members. If it is surgical site infection or surgical antibiotic prophylaxis, the team member will be the surgical team. Surgeon, operating nurse, floor nurse, anesthetists, the technicians, everyone will be involved. The team members allocation is very, very important. Then resource allocation. As I told you before, if I want to stick everywhere, that has to be aesthetic look too. I cannot take a printout and stick it. It won't look, they won't see any, if it is attraction only, they will able to see something is there, what is the color, why they are keeping all those things. So I have to spend something for that allocation also. Then after completing everything, it has to be a structural implementation. Whenever, wherever, whatever we are doing, it has the finally has to be some structure. Then it has to go to the leadership level. Where if I'm approaching to the senior consultant with the leadership support, definitely I will get scolding from both sides. If I'm approaching, if I'm getting blessing from the leadership, then I'm going to the senior surgeon. Maybe I will tell, sir, I already spoke to the leadership level, sir. They already accepted, sir. Shall I go through it, sir? Shall we do it, sir? Then they will get into that point in their mind. So any approach, it has to be after getting a blessing from the leadership management. Then definitely it will go to the functional implementation, operational implementation. After implementing everything, that definitely it will go to the evaluation and sustaining manner. Any problem, any issues, first we have to analyze what is the scope, why we are doing, what is the problem, to reduce the surgical site infection or improve the complaints of the antimicrobial stewardship or surgical antibiotic prophylaxis. Then what is the purpose, why I have to implement that purpose have to be identified. Then the team members, who are the team members involving in that particular procedure, if it is related to surgical or if it is related to antibiotic, who are the main team members are involving. Then choose the appropriate method. If I'm telling the team member, just go and do the audit, they cannot do the audit. It has to be a toolkit, methods, guidance. The checklist has to be pakka. Just example, pre-operative clearance for the patient where before going for the surgery. The first thing, whether they are taken the PM and AM bath. For that, I need to know when the patient is coming for admission. Then AM and PM bath for the patient. Whether the surgical preparation done or not. When they done. Sometimes the surgeon used to tell, you please shave your head thoroughly before coming for admission. They will shave with the blade nicely. They will come for the admission. That we have to know. Then glycemic control of the patient. Temperature, whether they are checking or not. All those things we have to monitor with the toolkit. Then we have to give it to the team member. If I am giving to the audit toolkit to the 10 people, they cannot analyze. 10 people, one A people will tell B will do, B will tell C will do, C will tell D will do. But the audit paper, finally, if you come across, there will be 0, 0, 0, 0. You won't get any proper identification of the data. Then anytime if I am giving to audit, we have to identify the dedicated people. The dedication is very, very important. It's a major responsibility of the whoever, maybe ICN, maybe the leader. They have to dedicate the job to the correct person. Correct person only will do the correct job. So if I am calling a person, you have to do this audit. You have to find out whether they did this audit properly or not. Whenever giving audit to the dedication person, not only ticking the chart, not only checking the documentation, they have to go to the patient side. Just example, a patient, sir, namaste. When did you admitted, sir? Yesterday. Did you taken the bath with the pink color solution? They given, the nurses are explained or not. That need to check with the patient. Whether they check your glycemic sugar level, sir. Did they shave? Did they shave or they did anything else, sir? Whether they did clipping, sir. What time they send you, sir? All those manner with the friendly way. If you ask patient is very well, they will explain everything to that with us. That documentation, that is the proper audit. We should not follow only to the documentation. The case file, every time the case file will be pakka 100%, temperature, vitals, everything will be patient came, patient bath given, everything given, preparation done on proper time. But when we come across with the, when we check with the patient, when we will come to know what are the deviation into that. After collecting data findings, then we'll come to know why this A surgeon always admitting the patient at the day of surgery. This B surgeon is not giving proper guidance for the skill preparation. All those things we'll have the findings. After finding, we'll have a recommendation. This A, because of A surgeon case only, we have always the deviation. B surgeons are not following this. We have a full recommendation related to that particular issues. Whenever, wherever we are doing any analysis, any implementing, there should be some measures. Measure has to be there. Whether that measures are outcome measures. I need to know, I want the outcome has to be positive. It's related to surgical site infection. If want to, the outcome has to be reduce the surgical site infection. Otherwise, antimicrobial stewardship, I need the complaints has to be improved for the surgical antibiotic prophylaxis. It has to be outcome measures. In process measure, any action if you're taking for the outcome, that is called a process measures. That's include our bundle checklist. If preoperative complaints, if I want to improve, I have to have a bundles with the preoperative preoperative checklist. The patient's what time admission date has to be there, AM, PM bar, skin preparation, what time they have to do, whether the glycemic control column is there or not. All these columns I have to prepare and give it to the proper this thing, that is called process measure. Just example. Next one is the balancing measures. Always balancing measures has to be, we have to balance both. It's like a structural process measures, it has to be balanced both. Not only implementing, not only giving intervention to the people, whether they are following or not, whether they have any problem to follow that we need to make sure. Just example, if I'm telling, first thing in the bundle checklist, surgical bundle, hand hygiene. If it is hand hygiene, I have to check with them whether their hand hygiene complaints are increased or not. For one group of people, always the complaints are decreasing. When we come across only, we come to know that particular product, it's not related, it's not good for the hands of the healthcare worker, it's only alcohol. So whenever we are giving intervention or implementation, that has to be balanced. It has to be good for the patients, good for the healthcare workers. The same time, it has to be good for the management with the cost wise. Always strategies for the healthcare associated infection starting from hand hygiene. Hand hygiene, how we will do audit? We have a WHO audit toolkit. Then whenever going for the rounds, we will observe whether the surgeon, which surgeon is not doing properly. They are following 5 movements and 6 steps of hand hygiene. Whether they are surroundings, whenever touching the 5th movements, whether they are using the hand rub or hand washing. After body fluid exposure, definitely they are washing or not. Or after gloving, just like that, they are removing the glove or going. All this we have to capture, we have to display. Whenever possible, we have to display. When every monthly once, this all documentation has to reach the leadership and management people. These are the works we are doing for prevention of our surgical site infection, our issues. The next one, environmental hygiene. Environmental hygiene is very next essential part to reduce our healthcare associated infection. Environmental hygiene, how we will validate, that's like our survival surveillance. We will do like a swab testing or our ultra gel method to check whether the housekeeping brother are cleaned or not. The gel method is really good. Then I had to have a calculation with how much percentage they cleaned, how much percentage they are not clean. That also we have to display, we have to present in the HIC meeting. And screening and cohorting the patient. Screening starting from the emergency, not only the emergency, even from the outpatient area. In our form itself, whether the digital form or the paper form, it has the OPD form has to include the screening of the infectious disease of the patients. Whenever the patient is coming to the hospital, the screening has to be done 100%. Whether the patient had fever, how many days fever, whether the patient had cough or not, any type of wound in the skin, whether the patient had any type of device, that to identify. According to the screening, we have to isolate the patient immediately as soon as they come to the hospital in emergency as well as in the OPD area. In the IP area, but all patients are coming through OPD and IP area. It's easy for us to screen. So we have to cohort the patients so we can avoid the cross contaminations of the infection. Surveillance, as we know, just like example, operation theater, we are checking the swab for the cleanliness, and the scrubbing water we are checking for every month for culture testing. Air particle study also we are doing for the positive pressures, the particles, how much particles are there or not. Then settle plate studies also we are doing for the air, with the air, whether the contamination there or not. All the surveillance steps we to the include to the all the high risk areas. Then antibiotic stewardship. Antibiotic stewardship is very essential in the hospital. Any antibiotic deviation, including our surgical antibiotic deviation, that leads to surgical site infections, that will be definitely we have to look into it. Following guidelines, whenever talking to any persons or any forum, any meeting, the guidelines, if I'm taking CDC guidelines, if I'm taking NHSN guidelines, that will speak. Always we have to follow the guidelines. All those things finally will have our safety culture. These are the very important strategies for the hospital healthcare infection to avoid. Next, 4 E's framework to improvement. Any intervention, it has to reach to the all the patients. If I'm telling the people to take audit, so they only will do the morning admission. Evening, some patient will have admission, night patient also will have admission. Any intervention or any implementation, it has to reach each and every patients in that particular area where we are feeling, where we are thinking like that the problems are crossing. To engage the people, always engaging the people. We should not only taking the class, we have to involve their hearts and minds of the people. How we have to involve the hearts and minds of the people? Whenever taking class, they will sit like that, they will open the eyes. When we ask what happened, they will blink like this. So in case if you want to involve the people, we have to make them to understand what went wrong. Just example, if the patients, we can tell mostly with the stories related or activities related, whether it is related to hand hygiene, I can show it with the gel method, everything. Just example, I will tell you one story. One patient admitted in the hospital with the complaints of fracture. He is the breadwinner of the family. After admitting, the doctor said he will, after the fracture recovery and everything, the surgery, then you will promise, he promised you will discharge within 4 days. Mother and 3 children were there in the hospital only. They came from very long distance. After the 3rd day only, we came to know there was a full and discharge from the surgical side. Then we come to know the implant and the surgical side, everything got infected due to some issues. So the 4 days become a 4 month, the cost wise, food wise, the entire family gone into the danger situation. That's why we have to be more careful. Each and everything, we should not take it like a negligence. Everything we have to take it in the mind. We have to show the video demonstration to the people, attract the hearts and minds to involve the to the particular issues. Educate. As I told you before, we have to educate. Education has to be turned into evidence-based practice. Education, not only you have to do 5 movements, 6 steps, all those things. We have to show it with evidence. These are the evidence. if after doing this, these are the complaints are improved in that way. So we have to always show it with the evidence that we have to execute. How we have to execute? We have to talk to the management people. After the team involvement, we have to talk to the management people. After talking to the management people, we have to talk it to the surgical team members. What are the intervention we are going to execute? Then the final thing is evaluate. Evaluation only will come to know what is the difference, whether it is achieved or not achieved. Behavioral change to understand the behavior of the persons. If, as I told you before, the hand hygiene complaints, I told you before, there was a huge problem with the product what we had in the hand hygiene, the hand rub. So the people, what they thought, they will educate, they will do. If something happened to my hand, who will take a responsibility? Burning sensation, not even I'm not able to take. We have to go to their, stand in their shoes. We have to observe what is the problem they are come acrossing. We will tell them to follow all those steps, but when we come across, maybe there will be less stops. 10 patient will be one stop at within half an hour. How they will follow all those things? That we have to make sure what is the problem, what is the behavioral issues, why they are not doing everything. We have to identify, then select the target people. Why in the 10 group only 2 people are not doing, I only 5 people are not doing? That we have to make sure whether the behavioral changes to the targeted people. So to specify the target behavior, when it's, if the complaints coming from the, after taking findings, after taking audits, we have to make sure we will have at least 45% or 75% will come to know because of only this labor ward people are not following this. So we have to specify the target behavior, we have to approach them easily, then identify what's need to change. So um, as I told you before, maybe we have to change the product, or maybe we have to change the people, who the one people will spoil the entire group. We have, maybe we can change the particular person from particular specific area. Then we have to come across with the intervention function. Then at any policies or any criteria or any categories, if we are implementing, it has to be with the fully focus on our intervention. So behavioral change with the technique, we have to tell with the, always comparison has to be there. If I'm telling with the labor ward people to the operation room people, they won't obey. The labor ward people to the recovery room people, maybe they will accept little bit because they are also less, they are also more job, and I'm also doing. If I'm comparing to the less job people, like one patient with the one staff, they have only one patient, why I have to listen to them, all those things. We have to use the technique like a comparison with the same group of people, then the delivery has to be improved. So the next one, we have so many guidelines in the 8 steps to develop and validate for John Hopkins. We have 8 steps. That 8 steps, it's very well available. We can go through it. It's starting from the culture of safety assessment. Why the safety assessment is important? Why the safety education, science of safety education, the staff identification of safety concern, then senior executive adaptation of the unit, and improvement implementations for the safety concerns, sharing result, and cultural assessment. It's very well available. Always we follow some guidelines, it will be validate our concerns. If any time, if you are taking any intervention, it has to be with the intensive care unit or emergencies and ambulatory center. It will give the proper result. Improvements, it will be with antibiotic prescription or CLAPSI prevention, CARTI prevention, SSI prevention. Our improvements has to have a proper outcome resource. Whenever the model of improvement, always starting by the 3 questions. Why we need to do that project? Why what is the reason why you want to do that project? The next question, if I'm doing that, what is the improvement we'll have? What is the change I will go and give it to the particular area? In case if I'm doing all the result, all the changes, whether I will get the result or not, whether the result get improvement or not, that 3 questions, any model for improvement will have why we are doing the analyzing, why what is the result it will come, whether the result will come with the good or not, with the improvement or negative or positive. We have one more method called a focus PDSA. Always implemental model. If I want to start any project, we won't know what type of project I have to do and which way I have to do. This is the focus is the one of the excellent model method. Always, what is the problem? Just like example, I reduce the surgical site infections. Then I have to organize the team member. Who are the team members are involving with that particular issue. Then I have to clarify the issues. What is the process? Whether I have to understand the process, whether the admission happening on the morning time, why it is not happening on the evening time. What is the problem with giving the AM and PM bath? What is the problem for giving the clippering? Whether why they are not doing the clipper, why they are not doing as soon as before the surgery, why they are doing the shaving at that too in the day before the surgery. Then to understand the variation of the root cause, why all those things are happened, what went wrong, that will come to know later. Then finally it will come to the opportunity where I have to catch in which A surgeon or B surgeon or A group people or B group people, that will come to know. All these things, focus, organize, clarity, understand, and opportunity. Select these all the proper method to complete your project. PDCA. PDSA, plan, do, study, act. Always anything, if you have any issues starting from planning. Planning, that will have some planning, we have to do some work. That work, we have to do some evaluation. Then we have to act on it. That is not going to stop anyway. Then again, we have to, after acting, we have to check whether it is implemented or not. If it is implemented, we have to do that work daily. If I'm doing that work, I have to evaluate whether it is happened or not. Then I have to act accordingly. Plan, do, study, act. It's not at all going to stop. It's like a infinity. It will circle the movement. Any project, it should not stop. It has to complete round away. It has to give the proper intervention and implementation to the particular issues. Sustaining changes. Any project, if I'm take, I have to sustain that. I have any improvement. If I like a preoperative checklist, preoperative bundle care for the particular surgical site infection to reduce, I have to make sure I have to give to the writing whether what went wrong. I have to write like a patient admission AM PM. Definitely there has to be a PM bath give to the patient. So why they are not giving PM bath? If the patient are admitted day before surgery, definitely the cost will increase. Surgeon will have a query. So the preoperative OPD itself, outpatient area, the preoperative care, when the patients decided for surgery, the care has to be started from the OPD itself. OPD nurse has to tell to the patient, OPD team members has to tell to the patient, before coming for the surgery, you have to take bath with this solution, sir. You are not supposed to shave your skin. You have to come here. The sisters will do the clipper method. Then you have to take all the investigation. You have to be nail by mouth. You should not have the heavy food on the previous day. That all the instruction has to give it to the patient starting from the OPD. We have to engage the people, sustain our process properly, and educate the people. Always engage will starting with the education only. Education starting not only to the staff member, it has to include the patient and patient family members too. Whenever we are educating the team that started, if surgical site infection I want to prevent, it's not only to the hospital healthcare members, it's included our patient and family members too. I have to educate the team that included our patient and family members. Then environment, where it happens, I have to reach that place. I have to go and do my intervention and implementation. Finally, evaluation effect, engage, educate, environment, evaluate. It's leads to, it always has to be effectiveness, then organizational level, the capacity, how much it went to that patient, then the finally result will come with the sustaining level. Next one, knowing doing gap. Anyone know about knowing doing gap? Hello?
Can
Okay, I'll tell you.
someone like to tell what is the knowing doing gap? It's a very famous gap in all our practices. We know a lot, but we don't do it. Correct, Rajeshwari?
Yes, ma'am. Yes, ma'am. 100%.
Okay, go ahead, go ahead.
Ye- yes, ma'am. Actually, we will educate. The people will know about the, just example, like a IPSG goal. The first goal to identify the patient. Always identification by the name and UHID number of the patient. The name and UHID number, goal 2, goal 3, effective communication and ensure the correct surgery and improve the high alert medication and reduce the risk of healthcare associated infection and reduce the fall for the patient. These all 6 goals, if I ask to one nurse or any team member, they will start to tell 1, 2, 3, 4, 5, 6, 7, 8 like a mantra. But when they are practicing, if I go and asking to the patient or checking with the patient family member, they will tell the nurse came, they gave this medication. Why they are given the medication? Did they check your patient name, sir? Did they check your name, sir? Did they check the ID band? No. This is the gap. Whenever we are practicing, they know everything. Whether they are doing, that is the problem. So knowing, doing gap is very, 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 very important task in every healthcare workers, healthcare settings if you go. So the education has not only stopping by knowledge or the best practice, all those things, it has to be implemented to the patient care area. So the right away, what we supposed to do, we have to go to the patient and tell the patient, if any nurse comes, sir, they have to check your ID band. After checking the ID band, they will check your name. With the checking the name with the patient and your name, then only the correct medication going to come to you, sir. If they failed, maybe they will fail to give the wrong medication to you, sir. In that way, if you educate, maybe it will threaten, but sometimes it's work. If you tell the patient in this way, definitely it will work. So the knowing, doing gap, we have to know where the gap will be. If then we will address that gap 100%, at least 99.99% problem we will solve it. Finally, actually, I want to tell you one more story. In my hospital, we had after chemotherapy, the patient after chemotherapy, the patient will come for chemotherapy. 3 days later, they will come with the fever. Like 4 patients, and later it's 5 patients, then 6 patients. We didn't know what went wrong. We are checking, swabbing, everything like a water bottle, whether the rooms, and maybe they are sitting sofa, everything I'm taking swab and checking, but we didn't know what went wrong. Finally, I went to the laminar hood where the person are mixing the medication. The laminar hood is little exposed only, but sometimes no, there will be some screen will be there. So not able to see that backside what they kept. So eagerly I want to check everything. I was sitting on the laminar hood. I put my hand inside. Then I want to check what is inside in that. Then I come to know there was an intrafix needle. That intrafix needle, the clinical pharmacist in our hospital, in our settings, clinical pharmacist only mixing the medication. So giving education not only to the team member, to the nursing, to the doctors, we have to involve each and every member of the team. Clinical pharmacist, the pharmacy people, or to the care coordinator, they won't come maybe to the secretary people, they won't the much involvement to the training, but we too, we will think why they want. The nurses knows nursing only, the doctor only involving to the patient care, all those things. So we won't give much important to the that type of clinical pharmacist, as well as to the secretary and to the boy with the case files, the boy will bring the case file, all those things. But if we want to implement our intervention, that has to be reached to each and every member. Then after putting my hand in the laminar hood glove only, I found that there will be the intrafix needle problem. The same needle, one day one needle was taking for every patient. Every patient she is taking, she is mixing with the same needle with the other solution, then other solution. Then we come to know this is the problem. We didn't stop it because that the culture came with the MSSA. So methicillin, sensicyllin, Staphylococcus aureus. So we need to know one, not only doing this intrafix, it won't come. Maybe with the mixing person. I just checked with the mixing person swab I taken from mix, all the nasal swab was taken from the persons who are involving with the patient care area, including surgeon, including the chemotherapy doctors. Why surgeon I took, because in that fever patient, that 3 patients will be chemo port. So I want to know why the chemo port definitely 100% they are handling with the safe hands, all those things. Why the chemo port patient also getting infected? The first thing, I took a swab from the team members, entire team member. If only taking to the surgeon, they will get angry. They won't allow me next time. They don't want to see me, my face itself. So I took from the starting from the clinical pharmacist, that to the surgeon, to the nurse, everyone. Like the surprisingly, I come to know the surgeon, the surgical team members, they had same issues. Not in this hospital, to the same thing we'll find out now. We'll come to know what went wrong. So we'll found out like a three members in the team members had a positive for MSSA. So then we come across, we educated the people, we colonized, we are given TPAC ointment, 4% microshield, everything. But still, when why I am telling this story, we should not neglect anyone from the team members for taking education. We have to involve the team members, everyone. If it is a care coordinator, if it is a secretary, if it is a clinical pharmacists, we have to involve every one of them to make sure our intervention, our implementations are going in the smooth way. So our conclusion always starting from implementation essential to increasing the evidence-based intervention. Whenever we are starting, it has to be evidence-based practice. We have to have a desired outcomes that control desired outcomes. That means to reduce the surgical site infection as well as to improve the complaints of antimicrobial stewardship. Then implementation plan, it has to be a necessary for success. Sometimes our QIP will have a negative also, but always we have to think it in the positive way, positive manner of our intervention. If I'm planning, for just example, if I'm planning for policy correction, that policy correction has to be there for, it has to reach to it has to involve all the surgical antibiotic prophylaxis, not only cefuroxime, not only to the other antibiotic. It has to reach all the antibiotic, including our high-end antibiotics. Then the overview of implementation is broader discussion. After implementing everything, we have to discussion. After discussion, we'll come to know the conclusion. Then any intervention, it has to be continuous journey for implementation, whether it is key method, model, or framework. It has to be continue throughout your journey. Then your success rate will be high. Thank you.
Thank you. Thank you,
Thank you, ma'am.
You can stop sharing the
Sure.
presentation. That's a lovely looking boy there. So thank you. A lot of people are giving very positive feedback, that very informative session. And you had a lot of examples, a lot of real stories. That makes the, understanding of, this is not a very easy topic, but you made it very easy to understand with a lot of stories. I think that is a big lesson for all of us to learn. When we are trying to educate people, always try to reach the brain through their hearts. And hearts are always warming up with stories. So we have enough stories around in our own hospital, outside. And if you go to internet, you will see many different patient stories where they were harmed because of hospital acute infection, which could have been prevented. So I think any amount of discussion that we do around patient safety will always fall short. So thank you very much, Rajeshwari, and we will
Thank you, ma'am.
open the floor for any questions or any comments from any of the participants sitting here. We still have some more time. We can take that time for discussing anything that comes to your mind. So thank you for all the positive words that is coming. It's very encouraging for the future leaders, and tomorrow maybe they'll be sitting in my place and they will be asking some other young nurses to do similar work. That is what I am hoping. Be like a cycle. So we all have a responsibility to bring in younger people and make them there in the limelight, and they use their talents for the benefit of others. Yes, ladies and gentlemen, any comment, any questions, you may unmute and talk.
I'm Lata here. Good evening.
Hi, Lata. Good evening.
First of all, congratulations and thanks to Rajeshri for taking up this day-to-day basis session, which will be really close to the people. And I loved that what we know we are not practicing. I am sure that everybody's eyebrow would have gone up. So it's really a good session. And one more thing I think we can add up a little bit when we are thinking about it is she touched upon on the surgical part. One is on the MRSA decolonization, what we are doing, and what's the importance of that. And when we are teaching to the people, rational, if we teach, it will be really good. That's only point what I thought to add.
Thank you. Thank you, Lata. And I think that's a very valid point that when you explain something to someone, the why is very important. That's how you touch the heart. When you explain why we are doing something, so classical example is what Rajay told about the IPSG 6. I mean, I think probably the most misused knowledge in healthcare since the accreditation came. Everyone is, drum beating IPSG 6, you have to. And I'm very sure that many of the people sitting here, the leaders, they vouch that when you actually go and talk to the patients, then you see the gap. Everyone knows what does it mean, but when it comes to implementation, so implementation, the safety cannot be on and off. Safety has to be doing the right thing every time. And that attitude or that heart will come when people are more conscientious about what they are doing. And that can be improved if they understand why they are doing something the way that they are doing. Many times, youngsters are not aware what they are doing. They are doing it because someone taught them to do so, but they are not aware of why. So, a point very well taken, Lata. Thank you so much.
And
Uh,
one more point, ma'am, from me. Sorry. That see what will happen, see, at times all these meetings what she has told will be attended either by ICN or the in charge or the nursing admin. So I feel that sometime we may have to invite these little staffs to the infection control committee meeting, so they will also will be able to understand the need and depth of the situation, because SSI has been discussed how deeply in that sessions. So that was another thing what I thought.
That's
Thank you.
a brilliant advice to all the leaders because engaging the frontline nurses is one of the mandatory things for not only for infection prevention, for everything, whether it is your safety committee, whether it is your infection control committee, select, a couple of nurses to come to these meetings by rotation. You can make them not permanent members, invited members, that they are coming for experience so that they can understand what discussions go into these meetings. That's the way that many of the MBAs are getting trained. They go into all these meetings when they are young, they know how these meetings are run. So I think in nursing also it is important that the frontline nurses needs to be invited to all the top level meetings, wherever the nursing head is going, wherever the ICN is going, because they do understand then, oh, so much work is going on before somebody comes and tells ki this is the protocol or policy, isn't it? But keep it by rotation. It always works. And some system, these are called as, councils. There are different councils you can create within the nursing department, and in that, there will be couple of permanent frontline nurses based on the whatever council that you are making, whether you are making quality improvement council or nursing infection prevention council. You can do that within the nursing department itself. So,
Correct. Ma'am, Dolly this side, ma'am. Good evening. Tankam, ma'am. Good evening.
good evening.
So, yeah, so I'm just traveling back from office to home, but I was also listening to the conversation and congratulations that she has spoken very well. And lots of knowledge she has actually imparted. Along with this, I just would like to add up one things which we sometimes we know we overlook. The thing is that when a patient goes back home and then comes after maybe 7 days after the OPD visits for the surgical site check by the doctor, and to know that whether the antibiotics or anything to be continued further, and most of the OPDs are manned by the ANM registered nurse or maybe GNM nurse. So those people, also needs to be trained that while they are doing dressing, to see that whether there is any kind of pus formation or any kind of maceration of the skin or anything present or not at the peri wound side. And if it is so, then immediately the OPD nurse needs to call the infection control nurse and inform whether a sample to be taken and sent to the lab. Though I know that the doctor permission is also required. Sometimes, consultants say that no need to send, but the patient might be have developed something and where we may miss, and then the wound gaping and all starts. So that is also very important, acknowledging the OPD nurses and making them understand the rationale behind observation of wound and sending a swab or informing to the infection control nurse, and then further guidance from the microbiologists are also required. So that is what I thought of that we can emphasize
Yeah.
to
Hi,
people.
ma'am. Hi, ma'am. I want to tell you something, ma'am. In our
Yes,
hospital, ma'am, the OPD is manned by the nurse, as you told before. Actually, the OPD nurses, any surgical patient comes, they have to get the signature from the book, from myself. I have to
that's
give the
really
signature
great.
why they came for OPD, whether it is for drain removal or related to the surgical. Then along with that, they have to have some prescription, ma'am. That prescription has to be attached with that file. But that book, in that prescription with the patient name only, I will sign. Without prescription, I will tell them not to sign. Without signature, they cannot go home at all. It's
So
like a
is it
strict order
possible
from.
for 1 minute? Is it possible for you to see each and every patient in the OPD, or the is it? I
Link
mean,
nurses, link nurses, ma'am. Actually, weekly Saturday,
hmm,
once we have a weekly huddle related to infection control. Weekly huddle we'll have every Saturday. In that
all right,
Saturday, I will counter check all the files, all the books who are bringing that book. In that every day, the OPD link nurse, OPD, we will have a BSc nurse. She is a link nurse. She is a link nurse. She has to check every day. She is the one giving. Every day she will send the photos with the any deviation or any wound gap the doctors are not sending, which
correct.
doctor is not following, whether they are using clean glove or
Mm-hmm.
sterile glove, everything we have a group in the IC champion. In that group, they have to send the photo. If they didn't
Right.
send the photo, if they are discussing in the huddle, I will ask question why then and there you have to implement. Then with the
Hmm.
link nurse, with the OPD nurse, we'll go to the surgeon, we'll tell the manner like, sir, if you go through in this way, it will be possible for preventing this infection, sir. Because already two infection came with your case, no? We have to discuss in the HAC, that will be a problem. In that way, with the diplomatic way, if I tell the surgeon, definitely at least 99% they will obey. And this is the way we are following in our hospital.
That's
Great.
really great. That's really great. Thank you. Thank you for elaborating. Very
Sounds
nice.
sounds really good. There is a question
Yes.
here, and then we have Madam Jyoti has raised her hand. We'll come to her in a minute. If scrub sink water from OT is not RO water, then is it necessary to send it for culture? Now the question,
Uh,
right, is what I'm thinking. If the scrub sink water from OT is not RO water, it is
no, it has to
expected to
be
be
RO
RO
water.
water.
It's
Is it
100%
necessary?
it has to be
I
RO water.
think it's a dangerous thing to have normal water in the scrub stations, right? Especially in the OT. So the question should not be that there is no arrow water. The question should be why you are not having arrow water. Unless, you are from a very low resource, setting. Most of the people who are attending here are all from good hospitals. So RO water is must in OT. Am I right? Yes, I'm sure because I'm
Yes,
surprised
ma'am.
by that question came. So it has to be RO water. So that's what you can learn from here. It's very important. Madam Jyoti Kumar, you have something to share. Your hand is raised. Hello.
Uh, Good evening, ma'am. How are you doing?
I'm great. I'm great. Thank
Yeah.
you.
Ma'am, first of all, hearty congratulations to the speaker. It was a very engaging and inspiring discussion. Now, there are 2 points which I would like to make. Since we understand infection control is as much behavioral as much as clinical. So it's very important for us to dwell on the behavioral aspect also. Somehow I don't understand why infection control is only the nurses who are doing it and not everybody else who's supposed to do. Why should we be requesting people? Why can't they do it? That is one part of it. And secondly, like what Lata ma'am just mentioned about the junior nurses, that's fantastic. We need to groom our young nurses. And I would also suggest that most of the time when people are given some authority, they carry their authority with too much of authority. You know, it is always like when an ICN is walking, she is coming for policing, she or he is coming for policing. So that approach has to be changed. It need not always be to point out mistakes. It can be like praising them for whatever they are doing, and then correcting or checking the gap. This is what I thought. The communication is extremely important when we are dealing with this. Isn't that right?
I totally agree, Jyoti, is that you really touched upon the point, but these are realities that, nurses being the largest, manpower in the healthcare delivery system and being the closest to the patient. So we kind of carry automatically the most heaviest burden in ensuring patient safety. It automatically comes, yeah, the closest to the patient, but yes, that does not mean that, others are, free to do whatever they want. And I think Rajeshwari mentioned multiple times that, it is the behavior that needs to change. And we totally agree that ICNs, when they are being trained in my sessions, I do this multiple times to say that, gone are the days where when they see the ICN, people will scatter and they disappear into the corners. ICN should be seen as a resource to with whom, they can entrust the trust to say that this person is coming to support us so that our patients are being safe. Now that's a culture that you develop over a period of time. And I do agree with Jyoti's that there are ICNs who could be, taking this authority like too much on their head, and they start, sometimes they shout on their rounds, they keep, asking people why you are doing this. So people, they tend to disappear when they come for rounds, they tend to disappear. I remember the time when I was in Saudi, we had an ICN who is from Africa, and she will come every day, and every day she will only find, mistakes. So I had to stop her one day, and I told her, I was the in charge, I was the CCU in charge. I said, "Okay, sorry, if you're only coming here to just point out faults, please don't come for rounds." Then she looked at me like that, why you're saying like that? So I said, your role is to help all of us to comply with the infection prevention protocol. It's okay to find that this is not right. This is fine. We can discuss. But you are actually telling the nurses this is not right. This is not right. So they are not happy when you come on round. So I don't want you to do that. So that dialogue was required. I said, let's form a team and let's improve the practices. I think that kind of worked. After that, she became my good friend, and when she comes, she'll say, "Oh, my friend Tankam, let us go for round." I will say, "Yeah, we will go for round now." And then, we used to then, highlight things, whatever that she's observing. See, it's very important to have this person in the team. When I was a CNO, I used to rely on my ICN so much because I consider my ICN as my extended eyes and ears for patient safety. So every day we used to spend time to understand how did the round go, what are the concerns, and I will be working hand in glove with the ICN. For me, they were really, really very important in my department. And I took very personal interest to work with them. And also I made sure that I was totally aware of all the knowledge the ICN also has. So when she's in doubt, I'll say, come, let's, find out what does the guidance say? What does the evidence say? We used to take printout, go to the surgeon, sometimes show that, sir, this is what it is. I support her in making her argument stronger. because so that over with experience you become more stronger. I mean, this is something that I am giving a shout out to all the ICNs who are sitting here. You don't become fully knowledgeable and you don't become the voice for your patients overnight. You have to prove. And over a period of time, you start getting calls directly, even from the doctors who will call and say, "Hey, Raji, there seems to be a problem in the ICU. Would you like to come and look at it?" Right? That's all they have to tell. So Raji knows this, how she will go and find out what is the problem. So that role will happen. So authority, while I agree that, Jyoti is telling that it should not be a power centric role, it should be a accountable and responsible role. Someone who is taking accountability to prevent infections in the patient. I think that's a fantastic approach. And thank you
Ma'am,
so
I
much,
have,
everyone.
sorry, ma'am, I have to say to address Jyoti ma'am's the thing. Ma'am, every week we have 10 star in the hand of the link nurses. 10 stars, actually, in the weekly hurdle, they have to complete all stars. That means they have to appreciate at least 10 people in their week. It's not only finding the fault of the nurses, to appreciate the nurse along the 10 numbers, one person will be 100%, like to the particular, maybe to following the 5 movements or 6 steps. So weekly hurdle, we will check 10 stars, whether you didn't appreciate anyone, that means you didn't go for rounds itself. If you ask in that way, if first few weeks it will be very like 10, 5 will be like that. The next weeks onwards, we come to know like 10s are complete, they will have only the paper without stars. So in that way, if we motivate the nurses to the link nurse or ICNs, definitely they will complete appreciating. Instead of finding the fault, it's like appreciating the nurse in front of the fault nurse. Maybe the nurse is not doing in front of them. Oh, you did correctly. I'll appreciate you. You will keep the star here. Sometime we'll have one day 3 star by the one nurse itself. That will motivate them more carefully in if seeing that other nurse, definitely that nurse will do 75% of the work properly.
Fantastic idea. This is
Thank you.
always, rather than correction, appreciation always works. And these are real strategies that can go a long way. So I think you did a fantastic job, Rajay. And the
Thank you, ma'am.
topic was not that easy to address in about 30, 40 minutes, but you did make it very interesting. You gave a lot of examples. And we still have 56 people still waiting. So thank you so much, and thank you all the people who interacted, gave feedback and appreciated. Thank you so much, and see you all today is 17th. The next session is on 21st, and that is on surgical site infection. Today it was the strategies to prevent infection in acute care settings. And on 21st, Ashwati will be discussing surgical site infection, and hope to see all of you again in the session. Thank you very much and good night.
Thank you, ma'am.
Thank you,
Thank
Raj.
you, ma'am. Thank you.
Bye-bye.
Thank you.
Take care.
Bye.
God bless you. All the best.
Thank you, ma'am.
Thank you, madam.
Bye, man. Bye.
Bye.